You've brought us a fascinating puzzle today, a collection of knowledge on oral lesions that blister and ulcerate, drawn from an audio lecture and a detailed PDF. Think of this as our expedition to map this, well, somewhat uncomfortable territory, our
Hmm.
mission. Then not just identify the landmarks, the different conditions, but to understand the underlying forces that shape them and ultimately equip you, the listener, with a clearer understanding of what to look for and why it matters.
Exactly. And what strikes me immediately is this initial stage, the blister, or as the sources technically call it, a vesicle or bulla, right there in the mouth.
Right,
Now, you might not always see that blister.
right.
As the audio pointed out, the oral environment is quite harsh, eating, speaking, even just the movement.
Yeah, lots of friction.
Exactly. These delicate blisters tend to pop very quickly, leaving behind the more persistent and often painful ulcer. So, in many cases, what you notice is the end result of this initial, often unseen event.
Yeah. Okay, so we're detectives looking at the scene of the rupture, often without seeing the initial break-in. That's actually a helpful way to frame it. Now, our sources neatly categorize these culprits into two main suspects, viral infections and immunological reactions. Let's start by interrogating the viral side of things, shall we?
Agreed. And the prime suspect in the viral lineup is undoubtedly the herpes simplex virus, or HSV. As the PDF lays out, we're dealing with two main scenarios. The initial encounter, the primary infection, which tends to have broader systemic effects,
Okay.
and then the recurring episodes, the secondary infection, which is usually more localized.
Right. Primary HSV infection or primary herpetic gingivostomatitis, quite a tongue twister.
It is.
The lecture notes that this often shows up in childhood, but it can certainly ambush adults who haven't been exposed before. And here's where things get particularly interesting when we compare it to the recurrence. This initial infection isn't shy. It can manifest as those telltale blisters, not just inside the mouth, on any of the oral surfaces,
Right, anywhere.
but also on the skin around the mouth and that border of the lips we call the vermilion.
That widespread appearance is a key red flag for a primary infection.
Hmm.
And as the audio underscores, it's often accompanied by a whole host of systemic symptoms, think fever, that overall achy feeling we call arthralgia, a general sense of being unwell, malaise, loss of appetite, headache, and even swollen lymph nodes in the neck.
Yeah.
It's not just a little mouth irritation, it's the body's full-scale response to a first-time invader.
It definitely sounds like the body is mounting a much larger defense. Fortunately, our sources indicate that this initial battle usually concludes within 7 to 10 days without any lasting scars.
Mm-hmm.
However, and this is a crucial point, the virus doesn't surrender completely. It goes into a sort of stealth mode, becoming latent, hiding out in the trigeminal ganglion, a major nerve center in the head.
Yep.
The lecture mentioned that even if the initial infection is so mild, you don't even notice it. A subclinical infection, which is apparently very common.
Very common.
Your body will still produce antibodies, leaving a trace of the encounter. And the incubation period, that time between exposure and the first signs, can be anywhere from a few days up to 2 weeks.
Precisely. And this latent presence is what sets the stage for those secondary or recurrent HSV infections, the familiar fever blisters or cold sores. The sources highlight a range of triggers for this reactivation: exposure to sunlight, fever itself, a common cold, physical trauma, hormonal shifts like during the menstrual cycle, stress, always a fun one, or even a weakening of the immune system.
Ah, stress, the ever-present agitator. The audio even joked that the stress of learning about oral pathology could be a trigger.
Hey, possibly.
But a key feature of these recurrences is that often the body gives you a heads up, right? A prodromal phase, a sort of early warning system.
Exactly. Before you even see the characteristic cluster of tiny blisters, you might feel a tingling, burning, or painful sensation right at the spot where the lesion is about to erupt.
Ah,
Then those multiple fragile, short-lived vesicles appear, which very quickly break open and can merge together into superficial ulcers. And unlike the primary infection's potential for widespread oral involvement, these recurrences tend to be more territorial, sticking to specific real estate:
yeah.
the lips,
Yeah.
the hard palate, and the gingiva, the gums.
So, localized symptoms, often with a prior warning in the recurrence. And again, the good news is that these usually heal without scarring, this time typically within a week or two.
Generally, yes.
Now, the audio also briefly touched on herpetic whitlow. That sounds rather unpleasant.
Indeed, that's an HSV infection that sets up shop on a finger. The lecturer noted it was a greater risk for dental professionals back before the now standard use of gloves and universal precaution.
Oh, right.
Imagine direct contact with an active oral herpes lesion without protection. The virus could then infect the skin of the finger.
Ouch. Definitely makes those gloves seem like a very wise investment. Now let's zoom in a bit, get down to the microscopic level. What does the histopathology of an HSV infection reveal? What are the telltale signs for the experts?
Well, what's fascinating here is how the virus disrupts the normal architecture of the epithelial cells. We see acantholysis, think of it as a breakdown of the connections between the cells, causing them to separate.
Okay.
The nuclei, the command centers of the infected cells, become clear and enlarged. That's called ballooning degeneration. And then we have these dank cells, which are those now separated epithelial cells just kind of floating around.
Right, those loose cells.
And the audio also mentioned Lipschultz bodies, which are like little dark inclusions or spots within the cell, essentially viral debris.
So these are the microscopic clues that help pathologists confirm it's HSV. Good to know. Now, how do we distinguish a primary HSV infection from other conditions that might look similar in the mouth? What's the differential diagnosis?
That's a critical point, yeah, because a few things can mimic that initial herpetic onslaught. The PDF mentions erythema multiforme. Key differences there lie in appearance and distribution. Erythema multiforme tends to produce larger ulcers, often skips the initial blister phase, and is less likely to involve the gums.
Plus the skin lesions.
Right, it might come with those distinctive target-shaped lesions on the skin. Another one is ANEG, or acute necrotizing ulcerative gingivitis. This is specifically localized to the gums and isn't preceded by blisters. It also announces itself with significant pain and, well, a rather unpleasant odor.
Okay, so location, the presence or absence of those initial blisters, and the other symptoms are key differentiators. What about telling a secondary HSV outbreak, a cold sore, apart from other common mouth ulcers?
The most frequent point of confusion here is with aphthous stomatitis, those frustrating canker sores.
Yeah, everyone gets those.
But there are some fundamental differences in their preferred locations. Aphthous ulcers almost exclusively set up shop on non-keratinized mucosa, the softer linings like the floor of the mouth, inside the cheeks and lips.
Right.
Whereas recurrent herpes prefers the tougher keratinized surfaces like the lips, hard palate, and gums. Also, aphthous ulcers usually appear singly or just a few isolated lesions, and there's typically no pre-blister tingling or burning.
Those are really helpful distinctions. Location, 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 it seems. Now, when it comes to tackling HSV infections, what strategies do our sources highlight?
The audio lecture strongly emphasized that timing is absolutely critical. Ideally, treatment should start within 48 to 72 hours of the symptoms appearing.
Okay, early intervention.
For primary infections, systemic antivirals like acyclovir or valacyclovir can be very beneficial in curbing the virus. Supportive care fluids, rest, gentle oral rinses, pain relievers is also crucial.
Makes sense.
For recurrent outbreaks, systemic acyclovir can help shorten the duration and lessen severity, but importantly, it doesn't prevent future episodes.
Right, it just manages the current one.
Exactly. In really problematic cases, or for immunocompromised people, preventative or prophylactic, systemic acyclovir might be considered. Interestingly, topical acyclovir, the cream, has somewhat limited effectiveness for recurrent herpes, although the audio suggested applying it very early, right at that tingling stage, might offer a slight advantage.
So, swift action and systemic meds for the initial big infections seem key. Okay, let's shift our focus now to another viral player, the varicella-zoster virus, or VZV. As the lecture pointed out, this single virus causes two distinct things, right?
Exactly. Two acts. The first act, the primary infection, is varicella or chickenpox. The second act, often years later, is the reactivation of that same latent virus, resulting in herpes zoster or shingles.
Ah, chickenpox and shingles, got it.
The PDF highlights that chickenpox is highly contagious direct contact with blister fluid or even just airborne transmission.
Wow, really contagious.
Yeah. Incubation is around 2 weeks, then most people get the characteristic rash. Unlike HSV, where silent infections are common, chickenpox usually makes its presence known. The good news is, in healthy folks, it typically clears in 2 to 3 weeks. But, like HSV, VZV also goes into hiding, establishing latency in nerve ganglia.
And then, potentially decades later, boom, shingles, often linked to declining immunity, right? Which is why older adults or immunocompromised people get it more often.
That's the connection, yes. And the audio mentioned shingles can be quite painful. and can even lead to that persistent nerve pain called postherpetic neuralgia, which can linger for months.
Oof, that sounds rough.
The PDF also noted the possibility of the skin in the affected area getting darker, hyperpigmentation, after shingles.
Interesting. And what's distinctive about shingles is its pattern, isn't it?
Absolutely. It tends to follow the path of a specific sensory nerve, often on the trunk, head, or neck, and typically respects the body's midline. It stays on one side.
Unilateral.
Exactly. When the trigeminal nerve is involved, same nerve, HSV hides in it, can cause lesions in the mouth, face, or eye. The lecture also detailed Ramsay-Hunt syndrome.
Oh, yeah. What's that?
That's a more complex scenario where VZV involves the facial and auditory nerves. It can cause facial paralysis, blisters in the ear, tinnitus, hearing loss, vertigo. It's pretty serious. And before the shingles rash appears, there's often that prodromal phase, pain or tingling in the affected area, the dermatome. Then comes the rash, progressing from macules to papules to vesicles, then pustules, and finally ulcers.
Sounds like a more localized but potentially more intense ride than chickenpox. What about the microscopic hallmarks of VZV? Anything specific?
Yes. Under the scope, the infected epithelial cells often show enlarged, kind of smudge-looking nuclei, homogeneous nuclei. Another feature is multinucleation, where multiple nuclei cluster in one cell. And similar to HSV, VZV can cause acantholytic vesicles that break down and ulcerate.
So again, some overlap but unique features too. How do we differentiate varicella and herpes zoster from other lookalikes?
For varicella, diagnosis is usually straightforward history of exposure, that widespread rash with lesions in various stages popping up together. But the PDF notes it can occasionally be confused with primary HSV or maybe hand, foot, and mouth disease.
Okay.
Herpes zoster, shingles, can sometimes be mistaken for recurrent HSV. But, as the PDF points out, shingles usually last longer, has more intense prodromal pain, that strict unilateral distribution stopping at the midline,
That midline stop is key.
and the potential for postherpetic neuralgia. Those really set it apart.
Makes sense. What about treating VZV infections?
For chickenpox in otherwise healthy people, it's generally supportive care, relieving itching, managing fever, preventing secondary infections. But in immunocompromised folks, systemic antivirals like a cyclover are often needed.
Right.
For shingles in people with healthy immune systems, high-dose oral acyclovir, started early, can help shorten the course and reduce the risk and severity of postherpetic pain. Managing the pain itself might need other meds, too.
And for the immunocompromised with shingles?
They might need more aggressive antiviral therapy, maybe IV acyclovir, vidarabine, or interferon, though the success can vary.
Okay, let's move on. Another family of viruses. The Coxsackie viruses. Our sources link these to hand, foot, and mouth disease and herpingina. Hand, foot, and mouth, or HFM, the name's pretty descriptive.
It is indeed. As the PDF explains, common, moderately contagious, usually Coxsackie virus strains, spreads through direct contact with nasal secretions, saliva, blister fluid, or the fecal-oral route.
Right, common in kids?
Yeah, often in community outbreaks, especially kids under 5. Usually resolves on its own in 1 to 2 weeks.
And the symptoms, as the name suggests, involve hands, feet, and mouth.
Precisely. Mild to moderate symptoms, typically. Low-grade fever, maybe feeling unwell, maybe swollen lymph nodes, and a sore mouth. The oral lesions start as small vesicles, rupture quickly into ulcers with a yellowish membrane and red halo.
Where in the mouth, usually?
They tend to favor the palate, tongue, and inside of the cheeks, often sparing the lips and gums, which is a bit different from herpes sometimes.
Oh.
And the hallmark skin lesions are that rash macules and papules on feet, toes, hands, fingers progressing to vesicles, then ulcers, then minimal crusting, usually without scarring.
So that specific hand-foot distribution is really key. What about under the microscope for HFM?
The vesicles form within the epithelium due to the virus replicating inside the keratinocytes. Sometimes pathologists might see eosinophilic inclusions within the cells.
And how do we differentiate HFM from, say, primary herpes or chickenpox?
The PDF highlights the generally milder overall symptoms, that very specific hand and foot rash distribution, unlike the trunk involvement in chickenpox, and the tendency for HFM to occur in outbreaks. Primary herpes often has more pronounced initial oral symptoms in some people and lacks that characteristic hand-foot rash.
And since it's usually self-limiting, treatment is mainly supportive?
Exactly. As the lecture mentioned, manage fever, pain relief for mouth sores, keep hydrated. Pretty straightforward.
Okay. Now let's turn to herpingina, another Coxsackie virus infection, specifically type A strains, the audio said.
That's correct. Another acute viral infection transmitted through contaminated saliva, sometimes feces, more common in kids aged 3 to 10. Symptoms typically include sudden onset malaise, fever, difficulty swallowing dysphagia that was emphasized,
Ah, difficulty swallowing.
and a sore throat.
And the oral lesions in her pangina have a particular location preference, don't they?
Yes, you typically see the vesicles on the soft palate, the focal pillars, those arches at the back, and the tonsils. They usually last about 4 to 6 days. There's also often a diffuse redness in the pharynx. Importantly, unlike HFM, no skin rash typically.
So the posterior location of the mouth lesions and no skin rash are important clues. And that difficulty swallowing.
Absolutely. And the lecture noted the overall signs and symptoms are usually mild to moderate, resolving in less than a week. When thinking about what else it could be, that specific distribution, short duration, the pharyngitis, and no skin involvement help distinguish it from other viral infections like herpes, HFM, or varicella.
Okay. And maybe from canker sores.
Right, aphthous usually lacks those systemic symptoms like significant fever and sore throat that you see with herpangina. And again, because it's self-limiting, treatment is usually just local comfort measures.
We've certainly covered a lot of viruses causing these blisters and ulcers. Let's shift gears slightly to measles and German measles. We've all heard of them, but the sources highlight specific oral findings.
Yes, measles or rubeola, highly contagious, caused by a paramyxovirus, spreads via airborne droplets.
Droplets. Okay.
Incubation 7 to 21 days, then a prodromal period of 1 to 7 days before the main rash. Orally, early on, you might see tiny pinpoint elevations on the soft palate. The audio mentioned Hermann spots, bluish-gray spots on the tonsils, but the classic oral finding is Koplik spots.
The public spots, right.
Small bluish-gray spots with a red halo, usually on the inside of the cheeks, the buccal mucosa. And crucially, they usually precede the skin rash by a day or two.
Wow, so Koplik spots are a really key early diagnostic marker for measles. Now, what about German measles or rubella?
Also contagious, but a different virus, a toga virus. Shares some symptoms with measles fever, respiratory stuff, rash, but generally milder and shorter lived. Importantly, Koplik spots do not appear in German measles.
Ah, okay. So the presence or absence of Koplik spots is a major oral differentiator between the two. How are they typically diagnosed and treated?
Diagnosis of measles often relies heavily on recognizing those prodromal symptoms, seeing Koplik spots, and then the characteristic skin rash. Lab tests, like finding specific IgM or IgG antibodies, can confirm it. For both measles and German measles, treatment is primarily supportive rest, fluids, good nutrition, pain relief. No specific antiviral is routinely used for otherwise healthy individuals.
Okay, we've thoroughly navigated the viral landscape. Now let's pivot to the other major category. Immunological issues, specifically pemphigus vulgaris and mucous membrane pemphigoid. The audio described these as autoimmune disorders.
That's precisely right. Pemphigus vulgaris is an autoimmune mucocutaneous disease, affects mucous membranes and skin. Here, the body's immune system mistakenly makes antibodies that attack proteins holding epithelial cells together. This leads to blisters within the epithelium, intraepithelial blister formation due to acantholysis.
Cantholysis again.
Yes, but a different cause than viral. The audio mentioned the autoantibodies, mainly IgG, target desmoglein 3, a key part of desmosomes. Think of them as rivets, holding cells together.
And these blisters in the mouth often pop easily, leading to painful ulcers. The audio really emphasized the potential for serious issues if untreated fluid loss, electrolyte imbalances.
Definitely serious if not managed.
And it highlighted that oral lesions are frequently the first sign, sometimes appearing up to a year before skin involvement in about 70% of cases. That really underscores the importance of spotting these early oral signs.
Absolutely. These bullae, large blisters, are fragile, rupture easily, leaving red, painful ulcers with irregular friable borders. They can look like anything from canker sores initially to large, raw areas. A key diagnostic sign is the Nikolsky sign.
The Nikolsky sign, right. Explain that again.
You apply gentle sideways pressure or traction to seemingly unaffected mucosa near a lesion. In pemphigus vulgaris, this can cause the top layer of epithelium to detach or slough off, revealing the raw surface underneath, like rubbing poorly adhered wallpaper, as the audio suggested.
That's a great analogy. It really shows the weakness. And the lecture noted common spots are the soft palate, inside cheeks, floor of mouth, back of the throat.
Yes, those are common areas. Microscopically, you see that characteristic intraepithelial separation or clefting with acantholysis, those loose, rounded Zank cells again. The bullae are typically suprabasal, meaning just above the bottom layer of the epithelium.
And diagnosis confirmation.
Direct immunofluorescence, DIF testing, is essential. A biopsy looking for those IgG autoantibodies already bound to the epithelial cell surfaces.
And distinguishing pemphigus vulgaris from other blistering conditions, what's the differential?
The PDF mentions mucous membrane pemphigoid, erythema multiforme, and erosive lichen planus. We've touched on erythema multiforme. Erosive lichen planus often looks different, more chronic, often with those lacy white patterns, Wickham stria, alongside the ulcers, and usually no flaccid bullae or positive Nikolsky sign. Mucous membrane pemphigoid, while also autoimmune blistering, has its own distinct features.
Which we'll get to. So the positive Nikolsky sign and that intraepithelial split are really key for pemphigus vulgaris treatment.
Cornerstone is systemic corticosteroids, like prednisone, often starting high to get control. More severe cases might need additional immunosuppressants to reduce steroid dependence and side effects. Topical steroids can be an adjunct for mouth lesions.
Okay, now let's turn to mucous membrane pemphigoid, or MMP. The audio noted it has several other names.
Yes, it's a chronic blistering disease mainly hitting mucous membranes, especially the mouth and eyes. Also called cicatricial pemphigoid, benign mucous membrane pemphigoid, or ocular pemphigus if mainly eyes.
And that old term, disquamative gingivitis.
Right, historically used when it primarily involved the gums, but now we know that's just a description. Other things can cause gums to look red and peeled.
Yeah.
In AMP, the autoimmune attack is different from pemphigus. It targets components in the basement membrane zone, the layer beneath the epithelium, anchoring it down. Specific targets include laminin 332 and BP180.
And this affects a slightly different group, more common in adults, elderly, maybe more women, and it can affect other mucous membranes too.
That's correct. Mouth and eyes most common, but also nose, larynx, esophagus, and a genital region.
Oh.
Orally, it typically shows up as superficial ulcers. Intact bulli might not be obvious as they're fragile. Interestingly, it often starts just on the attached gingiva, the firmly bound gum tissue.
So just red peeling gums initially sometimes.
Yes, intensely red, very friable patches or widespread ulceration there. Unlike pemphigus, the Nikolsky sign is usually negative or harder to elicit because the split is deeper at the basement membrane. And importantly, because the damage is deeper, MMP lesions have a greater tendency to heal with scarring or seccurates formation. This is a major concern, especially in the eyes, where scarring can lead to significant vision problems.
So a key difference, subepithelial blistering, below the epithelium, and usually a negative Nikolsky sign. What does the histopathology show in MMP?
The hallmark is subepithelial clefting separation between the epithelium and the underlying connective tissue. No acantholysis usually. The epithelial cells stay stuck together. DIF testing is also crucial, typically showing a linear pattern of IgG and complement C3 deposited along the basement membrane zone.
And if it's just on the gums initially, what else could it be?
The PDF lists possibilities like atrophic lichen planus, linear IgA disease, discoid lupus erythematosus, even contact allergy. Careful examination, history, and sometimes specific tests are needed to sort it out.
And finally, treatment for MMP.
Corticosteroids are also a mainstay. Topical steroids might be enough for mild cases or maintenance, but moderate to severe disease often needs systemic steroids like prednisone to control the blistering. And again, long-term steroid side effects are a consideration.
Well, you, our engaged listener, have now completed a truly comprehensive deep dive into the fascinating, albeit sometimes uncomfortable, world of oral vesiculobullous lesions.
Quite a journey.
We've journeyed through the viral realm, HSV, VZV, Coxsackie viruses causing HFM and herpangina, even the oral signs of measles and German measles. Then we navigated the immunological landscape with pemphigus vulgaris and mucous membrane pemphigoid. It's abundantly clear that careful observation, lesion location, systemic symptoms, skin involvement, prodromal signs, and understanding diagnostic aids like the Nikolsky sign and DI testing are essential for telling these apart.
Absolutely critical for diagnosis.
And while some are self-limiting viral issues needing supportive care, others, particularly pemphigus and MMP, often need significant ongoing medical intervention.
What's truly remarkable, and what these conditions highlight so well, is how these mouth blisters or ulcers can actually be the first visible sign of a much broader systemic process, whether it's a viral invasion or the immune system misfiring. The mouth can really act as an early warning system.
Exactly. Which leads us to our final thought for you. Considering this intricate connection between oral and overall systemic health shown here, what other seemingly localized symptoms might potentially signal a more widespread underlying issue needing investigation?
It really prompts us to think beyond the surface, doesn't it? Thanks for embarking on this deep dive with us.